Good morning, everyone. Dear student, this lecture is the Postoperative Complications and Management. I am Dr. Mustafa Osama, General Laparoscopic and Bariatric Surgery. First slide, we are talking about what is the meaning of the postoperative care. Dear student, the postoperative care is the surgical care and nursing care that the patient receives after every surgery. This is depending on the type of surgery as well as your health history. It's also include the pain management and wound care. Third slide, we are talking about the recovery room. Recovery room, it is the room that the patient and their student in the post-operative period they are kept, especially those who are not fully conscious, still anesthetized, should be recovered in this room. And the patient should not be discharged until they fulfill the following criteria. So what are these criteria? Should the patient is fully conscious, oxygen and respiratory is satisfactory, mean the oxygen saturation is more than 90, in room air, patient is normothermic, not in pain, not shouting, not nauseating, cardiovascular parameter all are stables, the oxygen fluid analgesic have been prescribed, and there is no concern related to the surgical procedure. Classification of the postoperative complication. There are three common approaches for the classification of the postoperative complication of surgery. First, linked to the time after surgery. It can be divided into immediate within 6 hours of the procedure, early 6 to 72 hours, late more than 72 hours. Number 2, general and specific surgery complication, and this is our concern. Clevian Dindo, and this system is related to the surgical complication and it is not in our concern. In this slide, we are talking about the classification of the postoperative complication. As we say, general and specific. The general including pain, fever, bleeding, DVT, wound dehiscence. The specific, we are talking about pulmonary hypoxia, cardiac hypotension, GIT, paralytic areas, urinary, UTI, urinary retention, and central nervous system include delirium. General postoperative complication. The first, we are talking about the pain. Dear student, if you look to this slide, we see the multiple emojis of the face, and this numbering from 0 to 10, starting from 0, no pain, until we reach to the red emoji number 10, which is unspeakable, which is excruciating pain. So we can divide the pain into very mild, tolerable, very distressing, very intense, and excruciating, unbearable pain. Now we are talking about the post-operative surgical pain. This can be divided into, as we said, mild intensity pain, moderate intensity pain, severe intensity pain. The example for mild intensity pain, herniatomy surgery, varicose vein, gynecological surgery, laparotomy. And this can be treated by paracetamol, non-steroidal anti-inflammatory drug. We can use the weak opioid, wound infiltration using xylocaine infusion, regional block analgesia, or we can add weak opioid or rescue analgesia. In moderate intensity pain, example for this surgery, hip replacement, hysterectomy, maxillofacial surgery. This can be treated by paracetamol with non-steroidal anti-inflammatory drugs with or without wound infiltration, peripheral nerve block, systemic opioid, and PCA. What does mean PCA? Patient control analgesia. This is a pump that's by infusion, can by using a special pump, we can press this pump and the patient can infuse every hour some kind of pain management. Severe intensity pain, example thoracotomy, major abdominal surgery, knee surgery. How we treat it? treated by paracetamol, wound infiltration, epidural anesthesia, systemic opioid, and as we said, patient control analgesia. If we are looking at this slide, we are talking about the fever. Fever is the temperature greater than 37.2 degrees centigrade following a surgical procedure. We can divide the causes of fever according to the days. In the first day post-operative, the causes of fever is reactionary, malignant hyperthermia, allergic to drugs, atelectasis. From the second to the fifth day post-operatively, the most common causes is the atelectasis of the lung. From the third to the fifth day is the superficial and deep wound infection in addition to the previous in the first and then second up to the fifth day. And the 5th day of post-operatively we have chest infection, urinary tract infection, and thrombophlebitis. More than 5 days post-operatively, also we have wound infection. Here we come anastomotic leak, intracavitary collection, and abscess. In this slide, we should do investigation to know the cause of fever. First, we start taking history and doing the physical examination, and we send first for the complete blood count for looking leukocytosis, blood culture to exclude infection, urine analysis, urine culture to exclude UTI, Doppler lower extremity to exclude DVT, chest X-ray to exclude atelectasis, pneumonia, CT scan of the abdomen to exclude intra-abdominal collection. The management patient with high fever is starting either to give oral antipyretic drug like ibuprofen if he can take oral, or intravenous paracetamol, which including either bottles or IV paracetamol pack. Now we come to the other post-operative general complication, which is bleeding. What are the post-operative bleeding classification? We can divide it into primary bleeding, reactionary bleeding, secondary bleeding. Primary bleeding means bleeding occur within the intraoperative period. Reactionary bleeding means bleeding occur within the first 24 hours of operation. Secondary bleeding means bleeding occur within 7 to 10 days post-operatively. The management patient with bleeding, first you start putting intravenous cannula. If you have external bleeding, direct compression, you start fluid resuscitations, blood transfusion. Another complication post-operatively, general complication, is DVT. DVT means calf swelling with erythema and leg hotness. That's indication the patient have deep vein thrombosis. The deep vein thrombosis can happen in the deep veins, including the femoral vein, popliteal vein, posterior tibial vein, and the anterior tibial vein. In addition to the previous clinical feature, the patient may present with calf pain, ankle pain, dilated veins. What are the risk group for developing DVT? We have low risk group include minor surgery less than 30 minutes. This occur at any age with no other risk factor. Major surgery more than 30 minutes in age less than 40, no other risk factors. Minor trauma or medical illness, any age, no risk factor. Moderate risk group include major surgery, age above 40 with other risk factor, major medical illness, example heart or lung disease, major trauma, burn, minor surgery trauma or medical illness in patient with previous DVT, pulmonary embolism or thrombophilia. The high-risk group include major orthopedic surgery, fracture pelvis, hip, lower limb, major abdominal pelvic surgery for cancer, major surgery trauma, medical illness in patient with DVT, pulmonary embolism, thrombophilia, lower limb paralysis, stroke, paraplegia, lastly, major lower limb amputation. What are the investigation needed to diagnose a case of DVT? This includes Doppler ultrasound study of the lower limb, Also chest X-ray to exclude pulmonary embolism. The finding is oligemic lung and also what is called lung scan. Here we see ventilation perfusion mismatch. And lastly is the CT angio. This is a spiral CT scan which show the left pulmonary or right pulmonary angiogram demonstrating extensive peripheral arterial stenosis. This is in case of pulmonary embolism as shown in this row. The management patient with deep vein thrombosis is started IV heparin or Glixan, which is the low molecular weight subcutaneous heparin. And after that, we are starting with warfarin in a dose of 10 milligram on day 1, 10 milligram on day 2, 5 milligram on day 3, until for 3 to 5 days. Then you stop the heparin and you continue with the warfarin, or we using a thrombolytic drug. A new drugs used for treating of deep vein thrombosis is the dabigatran, which is the trade name called Pradixa. We have two doses, 110 milligram, and Pradixa we have 150 milligram. This is invented by the Boehringer company pharmaceutical, and there's no need for follow-up by and their side effect for other anticoagulant drug. Another postoperative general complication is the complication related to the wound, include wound infection, wound dehiscence, wound disruption, and the burst abdomen. What are the stages of wound healing? This include the inflammatory phase, proliferative phase, and remodeling phase. In these phases, the bleeding can happen in all hematoma. Also, the inflammatory phase inflammation can happen, and also hematoma, seroma. So at any stages of the wound, you should examine the wound and looking for these complications. In this slide, how we should know how we manage acute wound. We're managing the acute wound first by cleansing, exploration and diagnosis, debridement, repair of structures, replacement of lost tissue where indicated, skin cover if required, skin closure without tension, all above with careful tissue handling and meticulous technique. In summary, we should always clean the wound, repair any damage inside the wound, remove any hematoma or seroma. If you need gels or ointments covering the wound to enhance the wound healing, sometimes we need a skin graft or a skin flap if you have tissue loss. Another complication in the wound is the wound dehiscence. Dear student, if you look to this slide, you see the skin opened, the subcutaneous opened. If you have a wound disrupted, either we have complete wound disruption or we have partial wound disruption. If we look into this slide, if we have the skin and the subcutaneous tissue is maintained, but all the wound in the deep layers is open, this is called partial wound dehiscence. But if the skin and the subcutaneous and the musculoapneurotic layer opened and the bowel herniated with evisceration, this is called complete wound dehiscence, also called burst abdomen. Dear student, this box shows the risk factor, the general risk factor in wound dehiscence. It includes malnourishment, diabetes mellitus, obesity, renal failure, jaundice, sepsis, cancer, malignancy, treatment with steroid. These factors will increase the chance of getting wound dehiscence and wound complication. This is typical picture of emergency burst abdomen. This is an emergency case. Need the patient to return back to the theater, returning back the bowel inside the abdomen, and you need to close the abdomen.